Welcome to the Clinical Podcast Series brought to you by the American Academy of Optometry Foundation and the Low Vision Channel. Today's topic, referrals from ophthalmology to low vision rehabilitation. Today's host is Bradley Dougherty. The topical editor is Gregory R. Hopkins. And today's topical expert, Judy Goldstein. Now on with the show.
Welcome to another edition of the American Academy of Optometry podcast series. I'm Bradley Dougherty from the Ohio State University College of Optometry, and I'm really happy to have Dr. Judy Goldstein from the Wilmer Eye Institute at Johns Hopkins University in Baltimore with me. Welcome, Judy.
Thank you, Bradley. It's great to be here.
So we're going to be talking about referrals from ophthalmology to low vision rehabilitation, which I know for every low vision rehabilitation practitioner is always on their minds and always something that we worry about a little bit. Are they high enough and that sort of thing? And so the paper particularly that we're highlighting today is from Translational Vision Science and Technology from 2022, and it's called Using Electronic Clinical Decision Support to Examine Vision Rehabilitation Referrals and Practice Guidelines in Ophthalmology, and Dr. Goldstein is the lead author on that paper. So as I said, it'd be nice if everybody who had low vision got a perfect referral every time, but there are some barriers in the way of that happening, and I think that's sort of perhaps, one of the underlying reasons to do this kind of work, Judy. So, as you see it, what's getting in the way of referrals in general these days?
Right. So it's a great question. I mean, thankfully, the awareness problem that we've known about for decades is less and less, right? People more than ever are understanding the importance of accessibility, about function, about solutions. When we have an iPhone in our pocket, we know we can make the font larger. We know that there are better ways to get the job done. But to your point, there are still barriers in place. And when we think about low vision rehabilitation care, I think of it as sort of a pipeline of care, right? We identify the patient, we refer the patient, and then they utilize service. So when we think about the barriers, that pipeline can be sort of blocked at any point along the way. And so when we're thinking about the identification side, which is really that sort of very first critical point, those people who are caring for those patients are often really busy in medical management, right? These are busy optometrists or ophthalmologists that have really limited time with patients, and they're doing exactly what they need to be doing, which is managing those medical elements, right? Should I change the drops? Should I do an injection? These are the key things why that patient is there today. So I think sometimes it's just simply overlooked, right? Sometimes it's just that patient really needs this medical treatment today. I think the other sort of barrier on the identification side is that, low vision is not a diagnosis, right, per se. It's multifaceted. It's really about function. And that treatment, that rehabilitation is really elective. So it's not just a quick, hey, your pressure is over 30. I think we should get you somebody in glaucoma who can help you out. This really takes some comprehensive thought processes. So I think on the identification side, it can be tricky. And that barrier to referral is really what we were trying to address in this paper. We really believe that we need a systematic way to address this problem because oftentimes either things are overlooked or people are too busy and they just need to have a simple reminder about the possibility that care may be useful.
Yes, I think that makes sense. And so the intervention that's discussed in the paper, or really series of papers that you and your co-authors have published lately, is a reminder that pops up in the electronic medical record. So could you tell us about, the criteria for that and how you came to design it and what it ultimately looks like?
Yeah, sure. So the key thing was that we were trying to do three things with this electronic clinical decision support. And this has been done in other areas, chronic kidney disease, diabetes, and other areas. And so we just thought that in this particular arena, this made a lot of sense. So we wanted to identify patients with vision problems. We wanted to notify their referring physician that they were potentially a candidate for service. And then we wanted to be able to document the physician response to the identification. Do you think you want to send this patient on to vision rehabilitation? And so when we were thinking about designing this clinical decision support system, the key thing to any system is going to be user-centered design, right? You have to make that project, that program, that system relevant to the user. And in this particular case, it was to the ophthalmologist, to the referring physician. So we met with these referring physicians. We outlined criteria for firing of that alert and suppression of that alert, right? We wanted to be sure that we didn't have too much alert fatigue. So we relied on the evidence, which is the American Academy of Ophthalmology has pretty clear guidelines that says, hey, if the patient is worse than 20/40 best corrected, maybe you should think about sending them on for service. And so we use that as a foundational element, which seemed to be really accepting among the referring physicians. And we made sure that we suppressed the alert so that, again, they weren't fatigued. So, we know that maybe a lot of kids may be coming in with uncorrected refractive error, or maybe somebody's going to have surgery in a couple of weeks and have cataract surgery. So maybe if they're going to have surgery, we don't want that decision support to fire. And so we created criteria that made it fire with worse acuity and suppress it maybe when there are other things that might sort of be responsible for that worse acuity that might be treatable. So we then went ahead and tested it with the providers. Then we came back, we modified it. And so it was an iterative process. So I think anytime people are thinking about designing clinical decision support systems, you have to keep that user in mind. And I think that you have to be willing to modify what works for them, even though it might not be ideal, for every aspect of that patient getting care. And I think the last key element, after we ran through and modified and edited and made it iterative, was that we gave feedback to the physicians. We said, hey, you need to know how many people you referred, how many people actually got care. And we set it up so that we gave them their data quarterly and the data of their peers. We know that eye doctors are pretty competitive. So we love the idea of people sort of duking it out and saying, can I do better than my colleague and get as many people to vision rehabilitation as possible?
Yeah. So one of the findings from the paper is that though you set the criterion at 20/40 for referral, people who are worse than 20/60 ended up being more likely to be referred for low vision services by the ophthalmologist. So what do you make of that and other findings on the sort of factors associated with referrals?
Right. So we did observe that patients who were 20/60 or worse than 20/60 were 2 times more likely to be referred for service. And I think this is fairly consistent with the literature out there. We know that people tend to refer later rather than earlier. I think it's important to note that in that paper for that analysis, we did exclude patients who were referred because of hemianopia.
Mm-hmm.
And so had we kept them in that analysis, we might have found out something a little bit different.
Yeah.
But it's a little bit tricky to know and parse that out. So to get to sort of the bulk of your question, I think that we can consider doing things like raising the threshold or lowering the threshold. And we know that there's no perfect response, right? We think about our glaucoma colleagues who have patients who have pretty good acuity and field loss, and maybe they want to send their patients. And we have retina folks who may be a little bit more delayed. So I think if we're going to be implementing something, we don't want this to be a speed bump, right? We don't want this acuity criteria. So maybe we need to customize things. Maybe we need to make different criteria for different providers. Much like we have our own internet feed that we like to read, maybe we need to give our referring providers their own feed that works for them and it doesn't cause these speed bumps in their practice.
Yeah, I think that makes sense. I mean, one of the things that's potentially a danger here, and you mentioned it, is sort of fatigue. Anyone who's used these systems knows that things are popping up left and right all of the time. So it sounds like you think maybe some customization for an independent clinician might deal with some of that pop-up fatigue in EMR.
I think so. We did study fatigue throughout the project over 17 months. We did not see a change in referral rate, which really surprised me, right? I thought for sure people would get tired. We'd see this big giant blip at the beginning of everybody wanting to refer their patients, and then we thought it would trail off. But I think because we developed suppression criteria that was really effective, right? If you had been to low vision before, we didn't have it pop up. If you were having surgery, we didn't have it pop up. So just carefully crafting that, I think, helps the referring physician say, what it's applying to makes sense for my practice.
Yeah. Now, so you said it's a pipeline, right? First, we have to identify them, then we get them referred. And ultimately, at the end is utilization of actual low vision rehabilitation services. And I think in other work related to this work, you've examined the effect of actual utilization when it comes to this new clinical decision support system. So what can you tell us about the effect it has on actual utilization of low vision services?
Right. So I think you're wise to sort of parse out this difference between referral and utilization. These are two different constructs. And just because someone is referred doesn't mean that they utilize care. And so when we looked at patients who were referred based upon their visual acuity only, right, we didn't include their diagnosis from hemianopia that we looked at in the study, we found that prior to the clinical decision support system, if we just looked at referral, about 6.1% of patients were referred when they were worse than 20/40. And that nearly doubled to about 13.8% during the clinical decision support system in place. And when we turned that system off after the end of the study, that referral, or that utilization rate dropped to about 7.5%. And so we can appreciate that while this is active, people are more likely to take on care. I don't think this is really surprising to any of us. Again, going back to the idea that everybody is busy in practice. So if we can implement something that has a sustainable capacity, right, that we can make it so it's usable, that it does really improve quality of care, I think we have something here that we can rely on going forward and make sure that these patients don't fall between the cracks of care.
Yeah, I agree. I think you're onto something. And as a low vision rehab clinician myself, it sounds pretty good. And so I'm looking forward to the rest of the work that you all complete on this. And I really appreciate you coming on the podcast and telling us just a little bit about it now. So thanks very much, Dr. Goldstein.
Thank you. I appreciate it.